Congenital disease is fair game for the exam. Here we're going to break it down into 4 categories and just try to keep it simple. We have obstruction, tumor, septal diseases, and the terrible T's. Let's talk about the obstruction first. In the obstruction, essentially we're saying that there is an obstruction of the blood flow. As blood comes from the left ventricles and it goes to the systemic circulation, there is an obstruction. The obstruction here deals with coarctation of the aorta. In coarctation, the pathophysiology is such that there's a narrowing of the aorta. It's most common in the aortic arch. Now, I broke it down into 3 subtypes because those 3 subtypes help you understand how they're going to frame the questions on the clinical vignette. The 3 subtypes are the preductal, so before the ductus arteriosus, the postductal, after, and then the ductal. In the ductal, it's very rare and it's not heavily tested. But the bulk of your questions will come from understanding the difference between the preductal and the postductal. Preductal means before the ductus arteriosus on the aorta, and that can lead to lower extremity cyanosis. This is where your clinical vignette will like to test you. So what happens is that before the ductus arteriosus, there are other collateral vessels that comes after the ductus arteriosus that may help supply the rest of the body with blood, especially the collateral vessels that deals with those that goes down the thoracic. So if there's an occlusion before the ductus, you can expect that it will be the same amount of blood getting to those collateral vessels, which will be minimum, and therefore the person may have lower extremities cyanosis. That's the clinical relevance there. Postductal, if the coarctation happens after the ductus, then you can expect that some of the blood will travel to those collateral vessels and it will be able to transfer down to the lower extremity, so therefore that's going to minimize the cyanosis you experience. But what they do have is that they have a very high blood pressure, because now the same vessels that may connect to the collateral are the same vessels that supply the upper extremities as well as those ones that go towards the neck and supply blood pressure into the head. And so therefore you expect these patients to present with signs and symptoms of headache specifically, and if they were to do the blood pressure in the lower extremities and those in the upper extremities, there will be a huge variation. So if you read the clinical vignette and it says the person has a blood pressure of 180/90 in the upper extremities and blood pressure of 90/60 in the lower extremities, they are talking about postductal. And so those who have Turner syndrome, 50% of them may be prone to getting this bicuspid valve, which we talked about. They are also prone to getting coarctation of the aorta. So now we are connecting bicuspid valves with coarctation of the aorta with Turner syndrome. So make that connection. In terms of the diagnosis, you want to do your chest x-ray. It will present with what they call the figure 3 sign. Sometimes they may give you it, sometimes they wouldn't. So it's not that high yield. But the figure 3 sign simply looks like this. You can see this. This is the figure 3 sign. You look at this 3-dimensional images here. It shows you area where the coarctation is taking place. Or the clinical presentation for a person who have this is that they, in the child who may have trouble feeding, they have difficulty breathing, the shortness of breath type things, and later on in life, they may have shortness of breath, dizziness, headache, nosebleed, and chest pain. That's your classic go-to in terms of diagnosing coarctation of the aorta. Headaches, nosebleed, chest pain. MRI can also be used as your diagnostic method. In this case, MRI can be a little more accurate, and it can show the person has left ventricular hypertrophy as well as the engorgement of the internal thoracic vessel, which will serve as that collateral. If the person does have postductal, that collateral allows for the blood to go into that area and supply the lower extremities, so therefore you don't experience cyanosis. For management, it's pretty simple: surgery. Now, the association with management is the fact that it may lead to left recurring laryngeal nerve damage, which can cause vocal problems, or it can lead to a chylothorax, which basically means that lymph will be dumping inside of the thoracic area. Recall that the thoracic duct is around the same area where you can see the ductus arteriosus. Next, we're going to continue and talk about the septal defects. VSD is the number 1. So the most common etiology for VSD is usually associated with Down syndrome, Edwards syndrome, and Patau syndrome. These 3 trisomy are important. Down syndrome deals with trisomy 21. Memorize that. Edwards syndrome deals with chromosome 18. Memorize that. In terms of the other congenital diseases, we say things like incomplete looping of the heart. That's basically embryology. It's not extremely high yield, but just basically knowing how the incomplete looping of the heart may lead to the ventricular septal defects. Then you talk about the myocardial infarctions. So people who have myocardial infarction during remodeling process, around day 7 or so, the septal wall can be affected, and that can lead to perforation through the septal wall, and that can lead to VSD as well. But this is not a congenital thing. This happens in older people who had an MI. The pathophysiology for VSD is that the patient may have a left to right shunting. That's classic. Just because the person has VSD doesn't mean they will get cyanosis. As a matter of fact, when you think about the physiology, there's more pressure in the left side of the heart. So therefore, when the heart is pumping, you expect more pressure to shift blood into the right side of the heart. So initially, the patient may present with left to right shunting. Therefore, they will not present with signs and symptoms of cyanosis early on. Individuals may have an elevated left ventricular pressure and volume. As a result, they may present with what is called the oxymergazine syndrome. So now you are pumping deoxygenated blood to the left side of the heart, and that can lead to cyanosis. Clinical presentations for VSD, so they are asymptomatic at birth. They'll be acyanotic, and it takes about a few weeks. In a few weeks, they start to present signs and symptoms of failure to thrive, and they will characteristically present with a holosystolic murmur, also called a pansystolic murmur. The diagnosis for VSD, the gold standard is an echocardiogram. You can do cardiac auscultation to kind of hear the murmur. That's only after you really have a strong and high clinical suspicion. Cath can be used, but again, echo is your diagnosis of choice. If you do an echocardiogram, you can just see the different flow of blood. So you can see here, you pretty much have the two ventricles and the septum here. And you can see the Doppler showing different flow of blood. So you know it's septal, is going between septals here. In terms of the management for VSD, most VSD will spontaneously regress, especially if it's not at large. In cases you can consider medical management, ACE inhibitors are a good choice. Loop diuretics are a good choice, especially if you were saying ventricles is pumping blood into the right, which is pumping blood into the pulmonary circuit. Using diuretics can really help you out here. You can consider medical management. In case of medical management, you can try to, a person who has a VSD with pulmonary hypertension, congestive heart failure will be one of the classic reasons. Also note that children who have severe VSD may precipitate congestive heart failure. Aortic regurgitation is another reason why you will want to do surgery. And of course, pulmonary stenosis is another reason why you want to do surgery. VSD is very high yield. Make sure you connect VSD with the trisomies we talked about, the Down syndrome, the Edwards syndrome, the Patau syndrome. Note that echocardiogram is your diagnosis of choice. Note that most VSD will regress, but in cases where they don't, you want to watch out for signs and symptoms of pulmonary hypertension, congestive heart failure, and other things that will require you to do surgery. On the other hand, ASD, which is not as common as VSD, is not as high as VSD. ASD essentially presents with the left to right shunt, which again is what we're seeing, so therefore the patient may be acyanotic. In most cases of ASD is due to the osteosecundum type. The ASD osteoproma type, I mentioned that because it's important, it's associated with Down syndrome. In most cases, we say ASD in that progress to adulthood may increase the risk for the paradoxical embolism, which we see, especially in people who have history of DVT and or those who are IV drug users. PDA is the third most common of these heart murmurs. The PDA is especially strongly associated with rubella infection. It's if they have signs and symptoms of cataract and glaucoma, they have kind of a hearing problems, and they have some skin changes. It has a strong association also with Down syndrome, and of course it has a strong association with preterm birth. The patient may present with a characteristic machine-like murmur. They will also have tachycardia and shortness of breath. They may have cardiomegaly as well, and the patient may present with polycythemia. As we continue, the diagnosis for PDA, essentially like everything else in the murmur category, you want to do an echocardiogram. The management for PDA, because of how it looks, in mild cases, you pretty much do outpatient treatment, and in some other cases, you want to give, in early cases, you want to give indomethacin, which may lead to the closure of the PDA. There are some instances where the PDA is needed for life-saving measures, and in those cases, you do not want to close it. The terrible T sounds exactly like that. It's terrible. So there are a lot of diseases in the terrible T's that are frequently tested. We have truncus arteriosus, transposition of the great vessels, tricuspid atresia, and tetralogy of Fallot. Just as a side note, in terms of the number, they indicates how many vessel or how many anomalies is involved in that. So in truncus arteriosus essentially means that there's a single trunk, okay? So it's very rare. So truncus arteriosus, single trunk, number one. Number two, it has to do with transposition of the great vessels. So this is an idiopathic disease associated with maternal diabetes. Idiopathic disease associated with maternal diabetes. The pathophysiology for this is such that there's an abnormal septal rearrangement that allows for the pulmonary artery to transport on the left side, whereas the aorta will transport on the right side. Remember, the aorta is supposed to be on the left side so that it can take blood from the left ventricles to the systemic circulation, but it flips around and the aorta is on the right side, whereas the pulmonary it's on the left. So as you can see, then you will have high pressure of blood being pushed into the pulmonary circuit. So that's going to lead to a very, very severe and terrible disease that needs to be corrected immediately. Clinical presentation for transposition: patient may present immediate cyanosis. Immediately, there will be a neonate with cyanosis. Because this is an immediate case, the patient may require a PDA, which will allow for the oxygenated blood to be able to go to the right side so you can get to the rest of the system. This is the case where they may tell you, what do you do next? And most people, when they think PDA, they think about indomethacin to close the PDA, but this will be an instance where that's wrong, because if you close the PDA, the patient will die. The diagnosis for this is such that, again, you want to do an echocardiogram. If you're doing chest X-ray, you'll see what is called the egg on the sling. So if you look here, you can see that this is the aorta, and then this is the heart. It looks like an egg, pretty much sitting on something. As you can see here, you have the vena cavas, which are pumping deoxygenated blood into the right side of the heart, and it's pumping it directly into the system of circulation. So that leads to immediate cyanosis. On the other hand, you have blood that has oxygen rich, which are coming to the left heart and pumping right back into the pulmonary circuit. That's why you need a PDA here, because as the blood is going here, due to its high pressure, it's going to feed the systemic circulation through the PDA. And in instance where you close this PDA, that's when you're going to lead to severe problems. As for management, essentially, you want to give prostaglandin E2. Keep the PDA open. Prostaglandin E2 will keep the PDA open. Remember, you do not give indomethacin here because that will close the PDA. Then you have to do surgical correction. Okay, in surgical correction, you want to switch them. Make sure that the aorta is on the left side and make sure that the pulmonary circuits is on the right side. Next of the terrible T's is tricuspid atresia. So 3 for tricuspid atresia. The pathophysiology here is such that the person has an absence of the tricuspid valve, which means that they have an absence of the opening into the right ventricles. So nothing is getting into the right ventricles, so therefore nothing is going into the lungs. That's the pathophysiology here for the tricuspid atresia. In terms of the clinical presentation, the patient may present with progressive cyanosis again, because this is a terrible T, and they present with hollow systolic murmur. The reason why I put this as a star, because there are 3 things that will present with hollow systolic murmur, which is almost always described in the clinical vignette. The hollow systolic murmur can be seen in MTV. That's the mnemonic. So we have mitral valve regurgitation, tricuspid atresia, and ventricular septal defects. Remember that. Hollow at the MTV, hollow at the MTV. Mitral valves regurgitation, tricuspid atresia or aplasia, and the ventricular septal defects will present with hollow systolic murmur, which means the murmur is very loud and tends to cover the other sounds. The patient, essentially, if you look here, you can see that there is an atresia of the tricuspid valve here. All right, blood is supposed to come from here as well as here and comes into the right side of the heart and pump into the pulmonary, but it's not there. And so that's the problem we are talking about here. For management, you want to make sure that you give the patient PGE, prostaglandin E1. That's because in this individual with tricuspid atresia, they likely have a PDA, and the PDA is serving as a life-saving mechanism here. In surgical correction, you can do what's called a Fontaine procedure. And essentially what the Fontaine procedure is, you are taking the hepatic vein and you're kind of putting it into the pulmonary circuit. That's the whole idea. Hepatic vein into the pulmonary circuit to basically redirect the inferior vena cava. So there's an image of it here. You can see that these here are coming from the hepatic section, and this is showing you how you pretty much are trying to take it out and try to connect it to the pulmonary. All right, so you try to connect it to the pulmonary here. So it's going to the lungs, and that's able to help with the process. So you don't even have to worry about this right side of the heart that's not even putting blood into the pulmonary circuit anyways.